as we're representing the clinical area, right? So we can work on different aspects, and as the whole OHDSI can work on standards, methods, and tools and studies, we also are focused on these various areas, right? So, and talking about standards, what's new in psychiatry comparing to other clinical areas is that it doesn't have any objective measurements, right? It has only questionnaires, and the questionnaires are pretty different from other concepts. And what was done before, it was done like about 300 scales were added, but as initial, as experimental, or let's say, yeah, more like observational, we just tried to understand how those scales work, and it was done ad hoc, right? It was done by finding concepts in our partners' data, and we just didn't do any updates, and we didn't find anything like any related reliable source, but just checked whether those concepts exist in core terminologies, and if not, we added them, right? And also we used a primitive hierarchy. There was three levels of hierarchy, like a group of scales, like if it's depression assessment, let's say, right, and it's subsumed exact depression, like you know, PHQ-9. Oh no, not PHQ-9, but some like big scale, and then subscales, like there can be depression and anxiety inventory, right? And then there will be depression inventory, depression subscale, and anxiety subscale. So there was three levels, right? And the ongoing work is to improve those standards, to improve how we deal with scales, right? So first is usage of reliable and comprehensive source. So there is a list of I can actually show some findings, but you know, probably not spend much time. So there is a list of all those scales, and they are even divided by the constructs they investigate, right? Then we, what do we do now? We work not only within like OHDSI, right, but we work with SNOMED and LOINC, and we have like tight connection with SNOMED now with Piper, and Ailio helps us. She's from SNOMED, and we want to use those standards not only in our own field, but in SNOMED as well, right? So it will allow us to create unified semantic field. Then, well, as we have some sources, if we define some sources, and we can more or less easily update the system, update the vocabulary set, like we do in all other vocabularies. We get whatever message that this source was updated, and then we run the machinery that updates the vocabulary, normal vocabulary. So we want to do that, and then it should be not just a primitive hierarchy, but a real ontology with several axes. Like now, SNOMED has axes for scale, and it has like a method, like a tool, right? And it has several axes for score, like a way how you store that, right? And then it can be connected to observable entity, like depression or mood finding can subsume depression score. So eventually it will lead us to, if I want to characterize depression patients, right, I can grab all mood finding observables and grab all everything that can be found in the data, including scales, subscales, or other findings related to mood. As I said, like well, actually, it's interesting finding. Like recently, we did some characterization, like patient profiling for treatment of depression, right? And we found that a lot of patients have different treatment, and a lot of patients had like up to 5 lines of therapy. So it's pretty hard to guess which drug is used, so how they treat the depression, right? They give, like, based on number of symptoms or syndromes patient has, right? They give some more or less proper drug, but then in 50% they switch to another drug. So it's pretty hard to guess which drug to use, which drug will be best for that patient. And then in the second line therapy, another 50%, they switch in another 50%. So It's because so there are a lot of subtypes of depression. There can be depression with anxiety, or depression with sedation, or depression with suicidal thoughts, or depression with aggressive behavior. And we don't have codes for that. You have only one code, F33 something, for like depression, mild depressive disorder. Anyway, so this actually indicates that there is a lack of diagnostic codes for that, right, and lack of terminology. And the only way how we can evaluate severity or some peculiarities of this disorder is to use those questionnaires. So yeah, I just, sorry, it was a little bit distracted. So yeah, we want to get the ontology, right? So you get everything about depression, and then you can run those different characterizations and see what's under the umbrella of depression observable. And last point is that well, now in OMOP, the questionnaire topic is pretty like fuzzy, like someone uses pre-coordinated constructs, like when it says whatever, some level of mood, or whatever, level of life, satisfaction of life, good. Like one concept, pre-coordinated pairs. Someone uses level of life and good as two separate concepts. Someone uses UK Biobank, some other structure. So we need to make it, to make one one piece of that, one rule for every standard. So it's what's ongoing work is about, right? And if we look at questionnaires, we also probably want to investigate not only like adding new questionnaires, but investigate how data has existing questionnaires, how they exist in the data. And you can see, like, for example, PHQ-9 has a pretty big number of counts. It's like Atlas Prod counts, right? But you can see here a lot of things, like individual items, questionnaire, like captured in SNOMED, questionnaire captured in LOINC, and it's pretty messy. Nobody does research on that. Right here is back depression inventory and anxiety scale. So you can see that more or less big counts, right? So it's possible to include those measures in research, but not all data sets have those. And another question is to assess how scales are used, which sources have those, and not even talking about new scales we work in parallel, right? But those scales that are coded in SNOMED and LOINC, they are pretty much a lot of those. And then we need to evaluate how this knowledge about the scales can be included into our existing research. Like I gave an example, we do characterization of depression patients, and then we stratify them by severity defined by the result of those measurements. And yeah, and also we can bring new data sources if needed. Also, okay, it's like, okay, how much time do I have? Like it's 15 minutes. Okay, good. So a few words about that. So we also have ongoing study. One is predictive adverse drug events during methylphenidate treatment. By the way, yeah, so it is a university, right? Dongyan. Andrew, where Dongyan is from? Dongyan? How is
Azure.
Azure, yeah. So it's led by Dongyan from Azure University from Korea, and they already involved several data partners. So if you want to join the study, you can. There's a forum post, and you can reach out to Dongyan and talk to him about this study. And there were several studies run before, and actually there's a couple of more of them. So yeah, that's it. And if you are, feel free to join us. And the next call will be, so it's actually first Monday of months, 8 a.m. Eastern time. So it will be the 7th of December at 8 a.m. Andrew, if you have anything to add, please.
Yeah, I think you did a great job. So I think Dima, you and Paulina and others did a great job of mapping all these new scales that give a much more granular picture of patients' mental health and neurological condition than you can just get from diagnosis scores. So there's a lot of stuff that you just can't do without these measures. And expanding the vocabulary the way you have is really going to enable a much more meaningful and important characterization of both patients and the effects of treatments. You also initiated this work that's grouping like things together, so we don't just have a collection of scales, but all the depression scales might go together, or other kinds of groupings. And some of the really fascinating work in the group is figuring out how those representations should live in a hierarchy that really reflects the nature of mental health conditions. The typical ones for physical health are organized at the root concepts according to anatomical site and morphology and other things that don't apply so much to mental health, where processes and other high-level entities beyond the anatomical site make more sense. And so because we have those connections you mentioned to SNOMED, we are planning work that's trying to strategize how to move towards a vocabulary that represents the real nature of neurological and neuropsychiatric issues where you don't know the anatomy and morphology, and allow researchers to do this work. And I think so there's things that are both fascinating from the point of view of their practical ability to characterize patients and disease, and really about how the whole field thinks and maps these kinds of entities. So it gets to some fairly fundamental things that are very exciting, and we're really looking forward to having other people join us. And Dong Yun's and others have been leading really important work that use some of these mappings. So please do join us.